Okay, Peroneus Longus, originating the head of the fibula as well as the upper 2/3 of the body of the fibula. Inserting on that first cuneiform and metatarsal, or sorry, base of the first metatarsal and medial cuneiform, and coming opposite to that tibant, forming that strap, that stirrup underneath the bottom of the foot. It's involved strongly in stabilizing the ankle, so will often be affected if the person has a history of ankle sprains or any joint instability. Trigger points, if you rotate a little bit just to stabilize the leg, we're going to use a cross fiber palpation, strumming over, looking for any top bands to palpate. Typically found like 2 to 3 centimeters distal to the head of the fibula, and then like 7 or 8 centimeters superior to the lateral malleolus, but they can be anywhere within there. Referring along the line of the fibula as well as behind the lateral malleolus. Our attachment release, dropping off of that head of the fibula and then going like just a little bit further, maybe 1/2 centimeter, to avoid those neurovascular structures. When you're working on a limb, you want to make sure to stabilize. When you're frictioning, you're not rocking the whole limb. I'm going to stabilize here by longitudinal frictions and my cross fiber frictions. And then down, following to that first metatarsal, base of the cuneiform. Longitudinal frictions here, sorry. This can be a very tender spot. Going medial to lateral right now, so that tendon is coming kind of in this direction, wrapping around. And then my cross fiber, I'm going to go up and down this way towards the toe. To stretch Peroneus Longus, we want to plantar flex and invert, and asking the person to try to turn their foot back to neutral. 5, 4, 3, 2, 1. Relax. To contract. And our approximation position will be usually just eversion, but you can, some people will turn off more with plantar flexion, some more with dorsiflexion. So technically it should be eversion and plantar flexion. Then there's this other little trick I wanted to show you. So the fibula needs to glide superiorly to allow for full dorsiflexion. So if you notice a dorsiflexion limitation, say, can you bring your toes up towards your knee? Good, and down. So if you notice a restriction there, what you can do is palpate the head of the fibula, take your thumb, reinforce it with the other hand, and then you're going to ask them to dorsiflex slowly, and you're going to firmly press down on that head of that fibula. So I won't press down hard, but I'm just, if you could you dorsiflex for me? I'm going to press, and then back down, and again. So as you're dorsiflexing, good, I relax. I'm trying to move that fibula towards the table. Usually you'll see immediate, significant gains in dorsiflexion. Got it right there even, and we were just playing.